Muy buenos días, bienvenidos al Instituto Nacional de Ciencias Médicas y Nutrición Salvador ZUBIRÁN. En nombre del doctor David Kersenovich, director general del Instituto, que no pudo estar con nosotros esta mañana, les doy la más cordial bienvenida, tanto a ustedes como a los miembros del presidio que quiero presentarles. En primer lugar, a nuestro invitado, el doctor Nakamura, que es un distinguido investigador de la Universidad de Chicago. Doctor Nakamura, welcome to Mexico. Thank you very much for coming to the Instituto Nacional de Ciencias Médicas. El doctor Alejandro Carrillo, el director general de la Fundación Miguel Alemán. Y el doctor Adolfo Martínez Palomo, director del Programa de Salud de la Fundación Miguel Alemán. Como ustedes saben, esta conferencia es parte de uno de los programas de salud de la Fundación Miguel Alemán, en donde una vez al año tenemos un invitado estrella que da algunas conferencias en instituciones en México, avalado por la Fundación Miguel Alemán, y por este motivo le pido al doctor Alejandro Carrillo que nos dirija unas palabras al respecto.
Muy buenos días a todas y todos ustedes. A nombre del licenciado Miguel Alemán Velasco, presidente de la Fundación Miguel Alemán, quiero agradecer muy cumplidamente la presencia de ustedes en esta 30ª Cátedra de Salud Miguel Alemán en el ámbito del programa de salud que coordina el doctor Adolfo Martínez Palomo y que, como ya lo dijo el doctor Gerardo Gamba, la Fundación Miguel Alemán, establecida desde hace 33 años como asociación civil, procura realizar actividades en apoyo de la investigación en salud en nuestro país. En esta ocasión, el comité técnico que se encarga de seleccionar a los recipiendarios tanto del premio anual Miguel Alemán en Salud como de la cátedra, seleccionaron al profesor YUSUKE Nakamura, y nos da un enorme gusto saber que con el apoyo del Instituto Nacional de Nutrición, el Instituto Nacional de Ciencias Médicas y Nutrición Salvador ZUBIRÁN, que nos haya facilitado la posibilidad de tener la cátedra aquí para que la puedan ustedes disfrutar y aprovechar, y agradeciendo nuevamente al Instituto y al doctor Martínez Palomo, les quiero sugerir que aprovechemos la presencia de tan destacado investigador internacional, porque esa es la intención precisamente de que las cátedras Miguel Alemán en salud se puedan presentar en auditorios como este. Muchísimas gracias a todos ustedes.
A continuación pido la presencia de la doctora Marta Espinosa, que es investigadora del CINVESTAB, que conoce muy bien al profesor Nakamura y será quien nos hará favor de presentarnos al invitado. Doctora.
Muchas gracias, doctor Gamba. Buenos días, muy buenos días a todos ustedes. Es realmente un honor presentar el día de hoy al doctor YUSUKE Nakamura, que nos visita en esta ocasión. Quiero hacerles un pequeño recuento de cómo lo conocí. El doctor Nakamura fue uno de los impulsores de la colaboración con México cuando la Embajada de México en 2008, la Embajada de México en Japón, celebraba 400 años de amistad México-Japón. En un programa de colaboración científica, el doctor Nakamura generosamente ofreció las instalaciones de la Universidad de Tokio para realizar seminarios bilaterales que fueron realmente muy fructíferos. fructíferos además en forma personal, porque después de eso me invitó a trabajar con él y por casi 2 años estuve recibiendo las enseñanzas y pues el laboratorio, todo lo que aprendí estando allá. Para hablar de él, de sus muchos logros, entre otros, el doctor Nakamura fue el fundador del Banco Biológico de Japón, que es, actualmente cuenta con más de 150,000 muestras y seguimiento de más de 10 años de pacientes, el Biobanco Japón, y con el que se ha hecho muchísima investigación. Fue también el fundador del Centro Riken, es un centro de secuenciación, el más grande que tiene Japón, y que además fue el apoyo para realizar la secuenciación del genoma humano, en donde Japón contribuyó mayoritariamente con el 25% de la primera ronda de secuenciación. Por otro lado, fue y sigue siendo asesor del primer ministro en materia de políticas de salud en Japón, y a pesar de que ahora está físicamente parte del tiempo en la Universidad de Chicago. Para hablar un poquito de números, el doctor Nakamura tiene más de 1,400 publicaciones, más de 80 de ellas en las distintas revistas de Nature, y sus trabajos han sido citados más de 130,000 veces. Es un verdadero gusto tenerlo aquí y con ese espíritu que él tiene de avanzar, de seguir, de difundir las cosas nuevas que está haciendo y, entre otras, el gusto que yo tengo de que estemos colaborando en un proyecto sobre esclerosis múltiple. Professor Nakamura, thank you very much for being here.
Okay, thank you very much. First of all, I'd like to thank the Miguel Alman Valdez Foundation to give me this kind of opportunity. I'm very glad and honored to be here today. And also my friend, Martha, thank you very much for your kind introduction. Today, I'd like to talk about my nearly 30 years effort on cancer research. Particularly, I would like to focus on the future medical care system called cancer precision medicine. So first of all, I'd like to introduce who I am and what I have done in the past 30 years. Okay, well, you couldn't realize this is myself. I started my career as a surgeon, and I faced lots of problems in the management of a cancer patient. And I had many questions that I had to address as a physician. And I had many questions. I'd like to show some examples why or how the normal cells are changed to malignant cells. Why progression rate of cancers in individual cancer patients are so different. Sometimes cancer kills the cancer patients very quickly, but in many cases, basically cancer patient can survive with cancer for many years. What makes the differences? And also, I wondered why some patients showed a good response to anti-cancer drugs, but some patients basically showed almost no response to cancer drugs. What makes this kind of differences? And also, some patients suffer very severe toxic reactions. Basically, suffer without any benefit, and finally die. Why some patients have to suffer very severe adverse reactions? There are a number of ways to address these kind of questions, but I took genomics or genetics to address these kind of questions. So when I started the genetics, I didn't give up surgeon, but somehow I gave up surgical treatment, and now stay in basic science. This is a list of publications by the November 5th this year. As you can see, I published many papers. I published 1,400 papers that have been cited nearly 140,000 times. So I probably contribute a little in the scientific community, and my work is mainly focused on genetics, genomics, and cancer. And also I serve as a deputy editor for cancer research between 2006 and 2009, and I served as the editor-in-chief of Journal of Human Genetics, 1998 to 2007, and I have been serving as the editor-in-chief of Cancer Science since 2009. If you're interested in these kind of journals, please submit your paper. I cannot guarantee I'll make a special deal to you. But anyway, if you're interested, please ask me about the feasibility to submit to these journals. Anyway, first of all, I had many questions. I want to try to address the question for the first one: how and why normal cells are changed to malignant cells. So I was interested in the hereditary cancer syndromes because I watched the death of 27 years old female gastric cancer patient when I was 27 years old, same age. I have to declare her death in front of her family members. It's pain. And soon after, I declared the death of 36 years old colon cancer patient who left small children. They couldn't understand the death of their father. But wife started crying, but the children couldn't realize the death of their father. And it's a very painful experience to me, and I wanted to learn why in some cases. So these young cancer patients developed the cancer. That was interesting, and such a literature I found this kind of familial syndrome. This is called Lynch syndrome. You can see the 3 colon cancer patient, first generation, and ovary, colon, uterus cancer in the second generation, and also third generation developed the colon cancer at the age 23. And I found there are many other examples, and I was interested in this syndrome. So familial adenomatous polyposis, coli. As you know, there are many polyps, thousands of polyps developed in his colon, and usually this kind of the adenomatous polyposis develop in age of 20 to 40 years old. And with a surgical treatment, patients have colon cancer with nearly 100% possibility and die if treatment is late. I found this family in Mormon, okay? Basically, Mormon church keep their family history, family trees like this. And I applied to this university, University of Utah, because University of Utah is located in Salt Lake City. Salt Lake City is a basis of the Mormon church. And the people are so cooperative and provided their blood. And basically, we applied so-called genetic linkage analysis. And when I read their article, I thought it's easy to find a gene responsible for this syndrome, but probably I didn't study enough. And after I moved to Utah, I learned there is not much DNA markers to do this kind of study. And first of all, okay, I had to develop so-called DNA markers, polymorphic DNA markers. As you can see, this is a family structure. There are 7 children. This is a method called the Southern analysis. You can see the band at a different position according to the size of DNA. These 4 children have a band here. You can find the same size band, and their mother and their grandmother. This indicating this chromosome segment was inherited from grandmother to mother and also mother to children. So we can say which chromosomal segment are transferred from grandparents to parents to children. This is very important. Before that, we had no tool to distinguish paternity origin or maternity origin of the chromosomes. But this kind of tool made possible to distinguish paternal or maternal origin of the chromosome. You can see the same band in this band, from the grandfather to father to children. And this kind is a very useful tool to distinguish chromosome paternity or maternity origin. So 30 years ago, 1986, we didn't have a tool, but 1987, we had a tool called the VNTR markers that I reported in Science 1987. So my name was in the history of DNA polymerase markers. So using these kind of DNA markers, we were able to identify genes responsible for genetic diseases like Lynch syndrome or familial purposes coli. And also, we are able to analyze tumor suppressor genes. Usually, tumor suppressor genes show a loss of chromosome in cancer cells. And also, we developed a SNP system. And this is very important for identifying genes susceptible to common disease and also genes related to drug response. I will show some example later. This is the earlier publications, and we published 4 papers in Science. This first one, basically using DNA markers, we reported systematic analysis of loss of chromosomes in human cancer. Second one is the first discovery of p53 mutation in human cancer. The third one is the cloning of the gene responsible for familial purposes coli. Okay. And we also found a mutation in the gene called APC that we named the gene APC gene, adenomatous polyposis coli gene, and we found the mutation in the FAP patient and also colon cancer patient. Okay, left side is a cover page of Science article. You can see the sequencing. Probably young people do not know this kind of analysis, but we use an isotope and we analyze the DNA in familial purpose coli patient. You can see only one nucleotide difference. This band in this patient basically moved to this one. Just a single nucleotide change can cause this kind of deleterious syndrome. Basically, this mutation was found in my laboratory in Tokyo, and after we found this mutation, and I sent this mutation to my collaborator Bart Vogelstein in Johns Hopkins University. And soon he sent a fax back. We didn't have an email at that time, and he sent back a fax with congratulations. This is I still remember the date we found the mutation, but anyway, this kind of genetic analysis contributed quite significantly in the cancer genetics area. Particularly, multi-step carcinogenesis model is very important. This can be applied to all types of cancers. Basically, APC mutation causes the small polyp from normal epithelial cells, and then additional KRAS mutation makes small polyp large. And then additional p53 mutation makes a benign tumor to the malignant tumor. So we have many examples and many genes involved in the progression of colon cancer. But anyway, this is a model we proposed in 1989 as a multi-step carcinogenesis of colon cancer. So I wanted to use this kind of information to treat cancer patients. Particularly p53 is very important because p53 gene is the most important gene in human cancers. Nearly 50% of human cancers have mutation in this gene. This is tumor suppressor gene. So we try to use this gene to kill cancer cells, and we develop some gene therapy system. In the next slide, I'll show you how p53 can kill cancer cells. This is the video we introduced p53 into the cancer cells. You can see some changes in cancer cells getting smaller and smaller. And basically cell density get higher and higher. You see the kind of explosion within cell. This is a basic induction of apoptosis. You can see the explosion within the cells. So this is the final moment of the apoptosis. Basically, cell system, cell structure is basically destroyed and look like a black hole and getting more and more dense and finally die. So I wanted to use this kind of system to treat cancer patients, but it's very difficult to deliver this kind of tumor suppressor gene into cancer cells. Only in vitro it's easy to kill cancer cells, but in vivo there's still some difficulty. And in parallel, I wanted to address these kind of questions. As you know, it's well known one size, one drug doesn't fit to all patients. So the different efficacy, requirement of a different dose sometimes, and also very severe adverse reactions in some people. To address this kind of question, I wanted to make a catalog of genetic variations. We participated into the international Hapmap project. This is a meeting in the University of Tokyo, and this is Francis Collins, and next to Francis Collins myself. I organized this kind of international meeting. This was very important to make a catalog of genetic variations. In 2005, we reported an article in Nature. It's a haplotype map of human genome. And we basically deposited the 1 million SNPs in this paper, and 25% of the data was generated by Japanese group led by myself. Anyway, 1 million for African, Asian, and Caucasian. This basically became a basis of the SNP analysis or whole genome association studies. We published 3 papers in Nature. As you can see, number of citations is nearly 4,000, more than 4,000. All 3 papers have been cited more than 12,000 times. This means that this is kind of the standard for the SNP analysis in the world. And in addition to the Hapmap project, I led the Biobank Japan project. We collected 200,000 DNA, and I have been working on the University of Tokyo for cancer genomics, and also I worked the genome-wide association study of pharmacogenomics in Linkage Center for Genomic Medicine. So I had 3 phases, and I led the Japanese genomic medicine project. Now, I think we're in the era to apply personalized medicine or precision medicine in clinical practice. So for cancer, I summarize in this one slide, a little bit busy, but this is a cancer detection part, this is a drug selection part, and this is a development of the personalized immunotherapy. So I'll explain one by one, but anyway, this entire system will be published soon in Trending Pharmacological Sciences. We described in detail what we should do to establish the cancer precision medicine in clinical practice. So I'd like to explain what we can do. So development of genomics tool made it possible to detect the cancer using cell-free DNA in serum, urine, or saliva. And also, we are able to monitor relapse or recurrence of cancer by small amount of blood samples. This is the data from Johns Hopkins University. So the cancer cell-derived DNA is basically contained in the blood, particularly breast, pancreatic cancer. In large cancer cases, basically release their tumor DNA into the bloodstream. But somehow it's difficult to detect a brain tumor, probably because blood-brain barrier. So anyway, we are able to do the liquid biopsy using a urine sample, plasma sample for early detection of cancer or early detection of relapse. Using such kind of information, we are able to apply to drug selection, or we can measure the drug response, and also we are able to monitor relapse of cancer patient. For example, detection rate of cancer using plasma cell-free DNA or cancer cell-derived DNA. So this is a bladder cancer, colon cancer, and detection rate is around 70 to 80% except brain tumors. For colon cancer, if separated, classified by stage, even early stage, 50% of cancer can be detected by using cell-free DNA in plasma. Particularly for colon cancer, 3 genes are enough. APC, KRAS, P53 I mentioned. So more than 95% patients basically contain either of the mutations in these 3 genes. So screening the mutation in these 3 genes made us possible to identify colon cancer by using blood. And this is the report from another group, and they monitored 4 mutations in breast cancer patients. So after the surgery, basically all mutated DNA disappeared from blood, but they reappeared in bloodstream. And they claimed they can detect the mutated DNA in blood 6 or 9 months earlier than actually detection by CT or MRI. This is very important. Okay, if we start the treatment at this stage, at this time point, we may be able to improve the cure rate of cancer. So some people say this doesn't make sense. We should wait, relapse, until we detect CT or MRI. But I'd like to explain, okay? If tumor became 1 centimeter, becomes 1 centimeter, 1 millimeter to 1 centimeter, usually a physician like you and also myself say, oh, this is 10 times bigger. And 1 centimeter to 10 centimeter, we say, or 10 times bigger. But you need to consider the number of cancer cells, okay? 1 millimeter of tumor, the number of cells is around 5 times 10 to the 5th. If get 10 centimeter, number of cells is 5 times 10 to the 11th. 1 million times higher number of cancer cells. Okay? Even compared 1 centimeter, 1 millimeter, 1,000 times higher number of cancer cells. This is critically important to start a treatment. If we can detect the relapse by liquid biopsy, soon after, if we can start a treatment, we may be able to improve the prognosis of cancer patient. Still, there is no proof this works or this doesn't work, but this is worth doing to further improve the prognosis of cancer patient. And then I would like to move about the drug selection. So there's a number of molecular targeted drugs. We need to know the mutation in cancer cells. If the mutation match to the molecular target drugs, we should provide a drug to cancer patient. If not, we should not provide a drug to cancer patient because useless. Basically, patient wastes the time. So we should get information. But sometimes biopsy is difficult. Because of the difficulty of biopsy, so liquid biopsy may be useful to provide a safer tool to make a diagnosis. And also, in some cases, germline genetic variation is very important for drug selection. So I'd like to simply classify the patient into 4 groups by drug response. This one, patient can expect a benefit without any toxicity by drug treatment. In this case, patient has no benefit, although no toxicity. And patients both have a chance to have a benefit and toxicity, and without no benefit, just only toxicity. How we should do if we already know this kind of things? It's simple. We should provide a drug. In this case, we should not provide a drug to these two classes. No benefit. Why we need to provide a drug to cancer patient? In this case, how to do? It's a little bit complicated, but depending on the benefit is much larger than toxicity, or toxicity is larger than benefit. So we need to decide we should provide a drug to patient or not. And also depending on the availability of alternative drugs. So we are able to apply the genetic information for this kind of the drug selection now. Why we do not implement this kind of information into clinical practice? This is the case of lung cancer, as I mentioned, LK mutation, which provide a crizotinib or sentinib, and EGF receptor erlotinib or afatinib or geftinib. If not, conventional cytotoxic agent. Anyway, nearly 10 to 20% of the patient have a benefit by the diagnosis of cancer cells. So in addition to this one, and also I like to stress the important things for the germline genetic variation, how we influence the drug response. If negative, we have to provide a cytotoxic agent. But definitely, we need to develop new drugs to cover these patient populations. So first of all, I'd like to explain the importance of germline mutation, germline variants for the drug treatment. So tamoxifen is widely used drug for the breast cancer treatment. So this drug is provided to the estrogen receptor positive breast cancer patient. So we think this drug is very effective, but this is not true for all of the patients. Tamoxifen needs to be modified in our body to endoxifen. Additionally, this OH to this position is extremely important because endoxifen has a 100 times higher activity to suppress the estrogen receptor activity. So we need to make basically breast cancer patients need to produce endoxifen from tamoxifen. The key enzyme is CYP2D6. CYP2D6 is very important, and also we know the various genetic variants of CYP2D6. So 10 years ago, or more than 10 years ago, we know this kind of genetic variant basically lose the activity of CYP2D6. But nearly 10 years ago, STAR10 was reported. This variant reduced the enzymatic activity quite significant. We found 40% of Japanese have this genetic variant. That means 20% of Japanese breast cancer patients cannot produce sufficient amount of endoxifen. That means probably drug is useless for such patients. And we measured the effect of genetic variant for the production of endoxifen. This is the endoxifen concentration. If CYP2D6 is wild type, so 14 nanogram per milliliter. But both are variant, it's below 20 nanogram per ml. This is below the effective dose. What's happened? If patient cannot produce the sufficient amount of endoxifen, of course, no drug, and higher rate of recurrence. This is a wild type, and the variant. As you can see, if patient have no CYP2D6 activity, very high rate of relapse within 10 years comparing to the wild type. This clearly indicates that this genotype is extremely important for the prognosis of breast cancer patients. So this drug is very cheap. A cheaper drug and less the adverse event and better efficacy. So we should select a patient, okay, based on the genotypes. And also we found the ABCC2 gene, this is a drug transporter, also influence to the prognosis of breast cancer patient. And then we combined the two genes, genetic variation of two genes, and made a score. As you can see, 0, 1, 2, very low rate of relapse, 3, 4, very high rate of relapse. So it's simple. We should provide a different drug. So 1, 2, 3, tamoxifen is enough. 3, 4, we should provide a aromatase inhibitor or other drugs. What we think is we should consider mode of action of drugs, and we should select a patient according to the mode of the action and provide a better prognosis to cancer patient. Another approach, what we are doing drug development. This is a little bit complicated, more biological, but anyway, we analyze expression profile of more than 1,000 clinical materials. We made a database, and we examined all of our genes in a large number of human cancers and found dozens of molecules that could be applied for the development of novel type of anti-cancer drug. The gene we found are quite exclusively expressed in cancer cells, but not expressed in normal cells. You can see this is 9 representative examples, no expression in normal lung, even cancer cells. You can see the browning staining patterns quite uniquely, specifically in cancer cells. We can say this is very unique protein in cancer cells. And we also examined other tissues. This is the analysis of northern blotting. You can see all of 9 show just one band in normal tissues we examined. All of them are only in testes, the typical cancer testis antigens. So these molecules are very important because if we develop drugs targeting these molecules, we can expect no or minimum risk of adverse reactions due to their specific expression patterns. So at the beginning, so we can guarantee most certainly targeting these molecules can effectively kill cancer cells, but less or no effect of adverse event. In the last 2 decades, the type of anti-cancer drugs are expanding. Very different type of drugs, small molecular compound, antibody drug, cancer vaccines, and gene therapy or cell therapy, antisense DNA or RNA, and also dominant negative peptide. So today I'd like to show some example for 3 types of drugs. So first one is an antibody drug for the synovial sarcoma. As you know, the synovial sarcoma, this is a kind of the bone muscle soft tissue tumor, and occurs most commonly in the young, representing about 80% of all soft tissue sarcomas, about 15 to 20% of cases in adolescent and young adults. The peak age is 30th birthday. We found that this FZD10 is quite uniquely expressed in synovial sarcoma. No other soft tissue sarcoma express these molecules. This is a cell line. And normal tissue, placenta express this one, but not other tissues. Compared to placenta, synovial sarcoma express this gene very high. And we found this is a receptor of the Wnt signaling and expressed on the cell surface. It's a good target to develop an antibody drug. So to make a long story very short, basically we developed the antibody and we basically labeled antibody with some dye. And this is a human synovial sarcoma xenograft. You can see the tumor here. Day 2, you can see exactly same site as tumor are present. Basically, antibody goes to the tumor and stay there even 5 days later, still there. we are not sure the antibody itself is intact or not. Anyway, antibody certainly target the synovial sarcoma cells. And we try to use the various method. One of the methods is to conjugate isotope, yttrium-90, basically very specific radiation therapy using monoclonal antibody as a carrier. This is a control, nothing happened. As you can see, the tumor grows so fast. However, if we treat with antibody with yttrium-90, you can see tumor mass getting smaller and smaller and disappear. This is another experiment. Basically, antibody itself has not much function, but if we conjugate with yttrium-90, just one shot of the treatment completely cure the tumor of human xenograft model. I tried to use this antibody to human patient, but I felt lots of difficulty to do in Japan. And we almost gave up. At that time, Dr. Blay in Lyon, France, visited me, and he offered to help clinical trial. And then we started clinical trial in France. I just showed one slide. Because yttrium-90 cannot be detected from the body surface, we use, in this case, indium-111 and conjugated with antibody. And this is a lung metastasis. You can see the very brilliant spot here. This means our antibody went to the synovial sarcoma tumor and accumulated at the site. Of course, this tumor causes necrosis because a very higher dose of radiation. Okay, yttrium-90 releases a beta ray, very short range, but within a cell, they release the beta ray and kill the cancer cells. So we just finished the phase 1 study, and Dr. Blay is now summarizing the data for phase 1. We, of course, are interested in to start the phase 2 clinical trial soon. And also, I would like to talk about drug development. These two are very important for cancer stem cells. These two kinase, MELK and TOPK, both are very important for the maintenance of cancer stem cells. So MELK is very important in cancer stem cells, and when we introduce a MELK into the cell, you can see the bigger sphere. This is not attached to cells. This is a kind of low attachment culture condition. You can see the big colony when we introduce the MELK. And also, when we introduce a MELK, we see the expression of OCT34. OCT34 is one of the indicators of ES cells. And we recently learned when we use a MELK in addition to the Dr. Yamanaka's iPS cells, so efficacy to produce iPS cell is much higher with the addition of MELK. And we developed a drug. This is a drug we call the OTS-167. This measured the cell number. So attached cells, so, but when we treat mammosphere, is a sphere-like cells with this inhibitor, we can see the very strong effect, only 20 nanomolar concentration. Basically, drug can kill the cancer stem cell. And this is the in vivo data. You can see dose-dependent growth suppression using this inhibitor. And the gray line is a paclitaxel control. We do not see any adverse event when we provide this drug to mice. And this drug also can be applied in oral formulation, not by injection. Even we provided oral, still showed a very strong growth suppressive effect without any adverse event at the effective dose. And this drug we now used for the treatment of AML. We also found a very strong effect on AML the clinical trial is ongoing in University of Chicago for AML. I actually show just an interesting result. We basically inoculate a human cancer. This is a lung cancer model, and we provided a drug twice a week, and we got the tumor and examined what is going on in cancer cells. This is a growth suppressive effect, dose-dependent manner. We can see the very strong growth suppressive effect by injection of this drug. You can see this is a control. This is a 25 milligram per kilogram, no adverse event. You can see the very small, not only small. Basically, cancer cells are almost died and replaced with some fibromatous tissue. This is the day 4, just one shot. Okay? This is a control, 2 milligram, 12, 25. We already see the necrosis of cancer mass. Just one shot of this drug. And this is some kind of the stem cell marker. Okay, when we treat the cancer with this drug, you can see the decrease, time-dependent decrease of the snail, basically stem cells almost killed at that point. Very high expression of no treatment or day 4, but 25 milligram almost disappeared. And interestingly, at this stage, p53 was induced very strongly. And the p21 is a kind of the G1 arrest marker. And the p53, p21 were induced by this drug. So we already found a mechanism how p53 is induced, but I don't have enough time, I do not show. But MEDICA expression was significantly reduced by this drug because milk is autophosphorated. Without autophosphorylation, okay, milk very rapidly causes degradation. So milk expression, milk protein itself disappeared very quickly. And also you can see the p21 expression and p53 expression by this drug. So now clinical trials are ongoing in the United States and also Australia. The other one is a TOPK. This is also very important for stemness, and also this is very important for the cytokinesis. Cytokinesis means a cell division. When we treat the cancer cells with siRNA, cancer cells die very quickly. Not only die, this is a control, where the cancer cells divide into 2 cells very quickly. But when we treat cancer cells with siRNA, you can see cell cannot divide at the end of the collapse. Basically, you can see the bridge between 2 cells, but they cannot separate into 2 cells, and without separation into the 2 cells and finally die. And this drug, also we developed, this molecular target, we developed a drug, and we applied this drug to treat the various types of human cancer. However, we found a very significant the myelosuppression. However, this slide, usually anti-cancer drug causes pancytopenia. Basically, red blood cells, white cells, platelet, all goes down. However, when you look at this one, this drug somehow induced the number of platelets. This is a good indicator to treat leukemia because thrombocytopenia is one of the big problems to treat leukemia. But in this drug, probably we can effectively kill leukemic cells and increase the number of platelets. And for this one, to avoid or to reduce adverse event, we applied nanotechnologies. We use a liposomal formulation of drug. So normal tissue and tumor tissue, big difference is a hole in the blood wall, blood vessel wall. So nanoparticle cannot go out. These orange colors are nanoparticle. Usually nanoparticle cannot go out from the blood vessel. But in cancer tissues, basically vessel wall is quite loose, have a bigger hole, and the big particle like nanoparticle can go out. So we applied this method to reduce the toxicity and increase the efficacy, and it worked. This is a lung cancer model. We injected twice a week, so we saw the complete regression of tumors. And when you look at the picture, histology, you can see the big difference. This is a normal control, not control, normal drug control, placebo. You can see the full of cancer cells in cancer tissue. But look at this one. As you showed in the video, basically a cell cannot divide into two pieces, exactly same. This is nucleus, you can see the intercellular bridges. That means that basically cancer cells suffered, okay, by not separating into two cells and finally die. And this drug also used for oral administration. Okay, 15 days administration, stop here, but they still keep shrinking, and day 29, complete regression. Okay, without any body loss, body weight loss. All 6 months, basically, we were able to cure. And in this case, we observed a very strong hematotoxicity, but day 29, already recovered. Why even stopped the drug? Tumor continuously shrink. So our explanation is by these drugs, cancer stem cells were killed. At this point, no cancer stem cells, only differentiated cancer cells. And if we observed, basically differentiated cancer cells keep dying and finally disappear. So we believe these two drugs are quite unique because they are able to kill cancer stem cells. And also, as I mentioned, this drug causes leukocytopenia but causes thrombocytosis. This is a good drug to treat hematological cancers, including MDS. And finally, I would like to explain about personalized immunotherapy or immunotherapy itself. So we developed cancer peptide vaccines 10 years ago. I'd like to explain the mechanisms of the cancer vaccine treatment. So we found that many of the cancer-specific proteins, cancer-specific molecules. These proteins basically become a peptide by degradation. And peptide can bind to the HNA molecules if their affinity is high, and then go to the cell surface. This is kind of the marker for cancer-specific cells, cancer-specific marker. And these cancer-specific marker can be recognized by cells called cytotoxic T cell, CTL. So CTL has a T cell receptor, and some T cell receptor has good fit, has a best fit to this kind of HLA peptide complex, and recognize these kind of cells as an enemy and release cytotoxic agent and kill. So we found many peptide molecules that likely to be an epitope and a marker of cancer cells. We try to use these peptides to treat cancer patients. So we injected 1 to 3 milligram peptide under the skin of cancer patient. We expect these peptides bind to the dendritic cells and express as an express antigen on surface and stimulate the cytotoxic T cells. And cytotoxic T cells, CTL, can expand like this by stimulation with a peptide and circulate our body and find cancer cell and release cytotoxic agent and induce cell death. Probably you don't believe what I said, but I'd like to show one video, okay? That's the CTLs kill cancer cells. Okay, this is a lymphocyte. These small ones are lymphocytes isolated from cancer patient who received the peptide vaccine treatment. Okay, we isolated using a so-called HLA dextranoma method. Basically, artificial HLA with peptide, we can sort out the lymphocyte that are able to recognize cancer-specific antigen. These lymphocytes are cancer antigen-specific CTLs. Larger ones are cancer cells, having an antigen HLA matched. Okay, please look at these cells. You can see attack of lymphocyte to these cancer cells. You can see drastic change in a moment. Okay, you can see the collapse of cancer cells. You can see almost all cancer cells basically killed by attack of CTLs. This happened in 3 hours. It's very effective. So this is not an engineered T cell. This is a naturally obtained T cells from cancer patient, indicating we have a lymphocyte that are able to kill cancer cells. And we already reported some phase 2 trials. And it's very difficult to use this kind of vaccines because we are able to challenge these peptides to advanced cancer patient. This is a esophageal cancer patient. We use a mixture of 3 peptides. 3 plus means the patient induced CTLs against 3 peptides, all 3 peptides. 2 plus means against 2 peptides, 1 is against 1 peptide. You can see patient who induced CTLs against 3 peptides showed a very good prognosis by this cancer vaccine treatment. This is another example published last year, 2 years ago, and in clinical cancer research, this is head and neck cancer. Similar, we use a peptide mixture of 3 peptides. If patient respond well and induce CTLs to all 3, survival is very good. But we wanted to apply this kind of peptide vaccine treatment to early stage cancer patients because induction of CTL takes long time, 6 months or 1 year. And then we applied 3 peptides for adjuvant setting for squamous cell carcinoma. Patient received the chemotherapy or chemoradiation and then received the surgical treatment. And if they judge R0 operation and the lymph node metastasis is positive and the HLA is A24, we provide a vaccination, if not just simple observation. This is a vaccination schedule. Patient received nearly 20 injections, that's all, and observed for the 5 years. This is result. It's a very minimum difference, but definitely show some kind of promising result for the relapse-free survival. But when you look at the overall survival, huge differences. So vaccinated group, for example, this point, 30% versus 60% in the 2 times better prognosis when we can provide a cancer vaccine to A24 patient. So we started the phase 3 trials based on this result. And it takes another 2-3 years, but anyway, we believe this kind of cancer vaccine treatment is very cost-effective, and provide a better prognosis to cancer patients. During this kind of clinical trial, we had a problem because we didn't have a way to monitor immune response in cancer patients. So we can measure CTLA induction by HLA multimer or ELISpot assay. But we found a way to sequence T-cell receptor. For example, this is another example. So this one clearly indicating lymphocyte can distinguish cancer cells with certain HLA, cancer cells without certain HLA. In this case, this is a negative control. Okay? HLA is unmatched. This is HLA matched. And these darker ones are lymphocyte. These green colors ones are cancer cells. This is a negative control. I'll show negative control first. Basically, nothing happened. Lymphocyte completely ignore cancer cell. However, look at this one. Although we added the same lymphocyte, you already see some difference in the shape of lymphocyte because we added the lymphocyte and the blood under the microscopy. Just several minutes already started drastic changes. You can see how lymphocyte behaved in this slide, these darker ones, and these are cancer cells. What these green color happened. You can see the very strong chemotaxis. Basically, lymphocytes gather around the cancer cell, and the green color disappeared, means the cancer cells were killed very effectively. Okay, you can see almost all cancer cells were killed by addition of cytotoxic T cells. What we are doing now is we have a system to clone the CTLs. We have a system to sequence T-cell receptor. And we have a system to clone this kind of T-cell receptor into the lymphocyte and generate the T cells at once, generate 10 to the 8th, 10 to the 9th, T-cell receptor engineered T cells, and apply these kind of T cell, genetically engineered T cell to treat cancer patients. This is my last slide. This is an animal experiment. So we genetically engineered T-cell receptor and made a massive number of CTLs. And in this case, we inoculated the cancer cells, and cancer, basically tumor mass get very large. And 0 date, we added genetically engineered T cells. As you can see, one mouse somehow escaped, but 4 out of mice, we could completely eradicate the cancer mass. And basically, we brought a cure to mice. But our final goal is to bring this kind of system to cure cancer patients. And the road is still very long, but by the effort of 30 years, so we are now at the stage to bring all of our effort in basic science to clinical implementation and to provide a better prognosis to cancer patients and a better management to the cancer patient and to improve the QOL of cancer patient. Thank you for paying your attention. Gracias.
Thank you very much for a very nice lecture. I would like to know your opinion about the role that cancer stem cells have on the development of new treatments, because it's very well known that a tumor is a very heterogeneous solid mass, or in the case of leukemia, a liquid mass, and not all the cells are the same. You have the cancer stem cell, which has particular features that are different from the rest of the cancer cells. Now, how focused are you in your research on cancer stem cells, and what is your opinion on cancer stem cells in the future of the development of new therapeutic avenues?
Definitely, the development targeting cancer stem cells is one of the critical issues in cancer treatment, because usually the cancer stem cells are resistant, particularly to the cytotoxic agent, and without elimination of cancer stem cells, okay, in someday cancer definitely return to the cancer patient and cure the cancer patient. So by chance, we screen the molecular target in various ways, and by chance we found these two molecules, TOPK and MELK, plays a very important role in the maintenance of cancer stem cells. As I showed, if we stop the treatment, okay, tumor mass continuously shrunk. This indicating our drugs kill the cancer stem cells very effectively. So now we are thinking it's a combination of our drug and other molecular targeting drugs, because our molecular targeting drugs may be able to kill the differentiated cancer cells, but not so effective to cancer stem cells. Combination of two drugs very effectively kill cancer cells. So we are planning to start a clinical trial, particularly one trial we are thinking is against neuroblastoma. Our collaborator already has the preliminary data, okay, indicating combination of the anti-cancer drug and our inhibitor basically reduce the rate of relapse very effectively in animal model. So within the 1 year or so, we probably start the clinical trial for the neuroblastoma. Yes, thank you very much.